Go through cirrhosis. I know this says cirrhosis too, but I'm going to show you this way before I show you another way to study cirrhosis. Each method says the same thing, but this may speak to people who like visual presentations. Okay, so cirrhosis is a chronic condition of the liver. Okay, now what typically happens is there's like a pre-cirrhotic disease. So somebody could have like fatty liver, say 10 to 35 years. Then they get compensated cirrhosis 10 to 15 years, which they don't even know they have cirrhosis. So cirrhosis can go undetected for a long time. And what happens, sometimes somebody goes for like a pre-op workup and they get their CBC and their platelets are low, okay? That could be an indication of cirrhosis. So it's like a lot of people don't even know they have it. And then it becomes decompensated in the last 3 to 5 years of life. And what that means is at that point, they're either, going to die or they're going to need a liver transplant, okay? So the causes, the most common cause of cirrhosis is hepatitis C. Linnaeus cirrhosis is due to alcohol, and that's not the most common, but I think, in all reality, that's probably what you're going to be mostly tested on. But just remember, hep C is the most common cause, okay? The only way to definitely, the definitive diagnosis is to do a liver biopsy. And I am going to talk about that a little bit later because there are some nursing implications that are very important for you to understand because it can lead to bleeding and a pneumothorax. That's like the complications of a liver biopsy. And I've taken care of a patient who died from hemorrhage after a liver biopsy. So it's really important you know those nursing implications I'll talk about later. So there are some conditions because of advanced cirrhosis that patients can present with, and I'm going to kind of go through them because that's what you're most going to be tested on. So you're mostly going to be tested on like end-stage cirrhosis, some that are going to have one of these conditions. So the first condition I'm going to talk about is portal systemic encephalopathy. All right, so you are going to, it's abbreviated PSE, and the reason they develop portal systemic encephalopathy is because the liver can no longer break down protein. And so they have ammonia floating around in their vascular system. Ammonia can cross the blood-brain barrier. So if somebody has, it's neurotoxic, ammonia, and so somebody could have ammonia level, the normal is 10 to 80, so above 80, they could have encephalopathy. And the signs and symptoms of encephalopathy, and it speak to the neurotoxicity of the ammonia. For example, they're going to be lethargic and have extreme fatigue. They'll have asteristics, and I talked about this in the renal lecture because they have it with that condition as well. So asteristics is like the wrist flapping. So you'll ask them to extend their arms and see if they have asteristics. People with encephalopathy could have slurred speech. It's almost like they're drunk even when they haven't been drinking. Okay, they'll have a loss of concentration and mental status changes, meaning their moods can go from happy to sad in a minute. Like they're so labile, they're just all over the place. And so loss of concentration, like the family members will say things like, they used to really enjoy chess and now they can't play chess anymore, or they used to enjoy crossword puzzles and now they can't concentrate. Okay, so you might see that. Reversal of the sleep-wake schedule cycle. So that is a classic sign. So in other words, people with cirrhosis are up all night but doze or nap during the day. Also a positive Babinski's reflex on the foot. So with portal systemic encephalopathy, if somebody presents with that, there's like 4 stages. You don't need to know like which symptoms show up in which stage. But what I do want you to know is that you have to, that's like an emergency. You have to get the treatment going for that, because somebody could come in with like stage 4 encephalopathy. You give them the lactulose, the neomycin, whatever they're ordering to eliminate ammonia from the body, and they can go back down to level 1 encephalopathy, right? So you can essentially reverse the encephalopathy if with the treatment. Okay, they're also going to have peripheral neuropathy. So think like diabetic foot care, same kind of care you're going to give. And this is because, again, ammonia is neurotoxic. Okay, here are your hand tremors. They could get hand tremors, but also for portal systemic encephalopathy, they are also going to have something called fetor, which is bad breath, musty breath, and it shows up later. So that's like really a bad sign, right? So you would report any of these signs if they were new to the provider, so that treatment could be initiated right away. So that's really important. Okay, with respiratory assessment, people with end-stage liver disease do develop ascites, which is a fluid collection in the peritoneal cavity. And because this is so, it can be really big on some people, it can impede their thoracic expansion. Okay, but and the other thing that they could have is a pleural effusion, because this ascites can leak into the pleural cavity. I'll just explain it like that. Okay, so you're looking for shortness of breath. There is something called hepatopulmonary syndrome, and the treatment for that, or what you're going to do for that, is obviously get the head of the bed up, right? 30, and then you at least 30, and then you also want to elevate the legs, so that banana type position. Put O2 on, and make sure you're doing daily weights. Daily weights is one of the best ways to monitor for the increase in ascites. GI assessment findings in somebody with end-stage cirrhosis are going to include VAN. VAN stands for vomiting, anorexia, and nausea. They will have an enlarged spleen, so they may complain of pain in the left upper quadrant with radiation to the shoulder. Okay, they're going to have clay-colored stools. Early on they may have a palpable liver, but as time goes on and the liver fibroses, it's going to shrink and it'll be smaller. They could have constipation, diarrhea, indigestion, and remember that musty breath I talked about, also hemorrhoids and esophageal varices, which we'll talk about. So endocrine assessment findings include the Palmer erythema, so red hands, spider angiomas. This is due to estrogen. So the liver breaks down our hormones or detoxifies them, but because the liver can't break it down in end-stage disease, they're going to have all these symptoms of estrogen that are going to show up even in men. So Palmer erythema, the red hands, spider angiomas are like, they look like spiders actually on the skin. And then for males, the normal male pubic hair shape pattern is a diamond shape. It's going to change to a triangle shape due to the estrogen. That men will have gynomastica and women will have amenorrhea or oligomenorrhea, and males will have testicular atrophy and they'll have infertility problems. With the skin assessment, you're looking for that icterus and jaundice. They're going to have poor skin turgor. Now, although they're collecting ascites in their belly, right, and they could have edema, it's still going to be a relative hypovolemia, because the fluid is not in the vascular space, it's in the third space, okay, meaning it's in the peritoneum cavity, or it has leaked into the interstitium. So they're going to have poor skin turgor. They're going to have purpura and excoriations. The spleen, when it gets inflamed, acts like a Pac-Man, and it eats the red blood cells, so they'll have anemia. It eats the white blood cells, so they're going to be at risk for infection. It's going to eat the thrombocytes, so they're going to be at risk for purpura, petechiae, bruising, so any kind of bleeding. Also, the liver produces vitamin K and clotting factors. It doesn't produce vitamin, it stores vitamin K. It produces the vitamin K clotting factors, so they're going to be at risk for bleeding. Yeah, here's the bruising, here's spider angiomas again. So if they have that bruising or it looks like they're bleeding, monitor the CBC with platelets and coagulation studies. Okay, here's this is what I was just talking about, the splenomegaly. Okay, the spleen gets enlarged and becomes like a Pac-Man and eats the white blood cells, which is going to put them at risk of infection, so they can develop spontaneous bacterial peritonitis. Okay, so the signs and symptoms of that are fever and board-like, rigid, hard abdomen. Okay, platelets are going to put them at risk for injury due to bleeding, and then it eats the red blood cells, so they're going to have anemia, so they'll be fatigued, short of breath, and orthostatic. Okay, so miscellaneous things. Patients with liver disease are going to have low protein levels and low albumin levels because the liver makes albumin. The treatment for that is not going to be give them more protein, because if you give them more protein, they're going to develop portal systemic encephalopathy. Okay, so that's really important to know. And the fetter breath, remember that. That means signals PSE, so encephalopathy. There'll be sinus tach because they do have hypovolemia. Now, early on, you're going to look for weight loss, but then as they develop ascites, they will have weight gain. I think of people with cirrhosis as a martini olive, like they have muscle wasting in their extremities, almost like when we talked about Cushing's, okay? And then they have the big belly in the middle. So that's indicative of cirrhosis. Lab testing. So early on, you're gonna see increase in their liver function studies. There's also a test called a GGT. So it's not really listed in ATI, but yet they ask questions about it. So that's like somebody has a binge drink, or early on in liver disease, they're going to have an elevated GGT. All right, alkaline phosphatase, if they have biliary obstruction, bilirubin will be high, ammonia will be high. The PT and INR, so prothrombin, is one of the vitamin K dependent clotting factors. So the liver can no longer make those, so that therefore the PT and INR will be prolonged, which is another reason they start to bleed. Protein and albumin will be low, platelets will be low, hemoglobin will be low, the glucose can be high or low, and the white count will be low, which puts them at risk for infection. So the only way to definitively diagnose cirrhosis is through a liver biopsy, and they can do this for hepatitis as well. So the patient's going to be NPO. So depending on the source, I think ATI says 4 hours. Sometimes if they think they may have to do surgery after, they'll be NPO longer. But anyways, you're going to get a consent, or I should say, make sure the consent is done. And they'll do a timeout like they do for every surgical or procedure. You need coagulation studies and platelets. Okay, so the liver is very vascular. The liver receives 1,500 mLs of blood per minute. So just think of like an IV bag and a half. That's how much blood is in your liver at any given time. So if they do a liver biopsy, the patient is at risk for bleeding out. So you're going to need to get these studies beforehand. But also think about people with liver disease. They're already at risk for bleeding. Okay, so that just adds a little more risk factor to it. So while the procedure is being done, you're going to have the patient hold their breath. Exhale, hold breath. And while the provider is performing the biopsy, and this is to prevent a pneumothorax. Okay, after the procedure, you're going to put the patient on the right side to enhance coagulation, and they'll be there for several hours. Look for your shock-like vital signs. So tachycardia is the first sign, and and then tachypnea, and then low blood pressure. Okay, so remember those vital signs. Interventions. These are just general interventions with somebody who has cirrhosis. You want the head of the bed up. They need to be on low sodium diet to prevent ascites, low protein diet to prevent encephalopathy. They need to eat soft foods to prevent bleeding. Okay, they're at risk for something called esophageal varices, and this is due to portal hypertension, and they can bleed out on that. So the reason you don't want them eating like toast, chips, even if they're low sodium, anything hard. You can eat taco shells, anything hard. They can't eat hard food. They have to eat soft foods. Okay, daily weights is the best way to monitor fluid status. Abdominal girth is done by measuring right above the umbilicus, and then they'll need vitamins. When patients with cirrhosis enter the hospital, they're given like what's called a banana bag. And that has a bunch of vitamins in it, right? But you want to give thiamine to prevent a different kind of encephalopathy. Okay, so they're going to need that. And then with skincare, you don't want any harsh soaps. You don't want the water to be hot or cold. Patients get really itchy, so you can put cotton gloves and long sleeves on them to prevent them from really scratching themselves to the point of bleeding, because it's really uncomfortable. Cut or clip the nails, file or clip the nails, and they're going to be on bleeding precautions. With end-stage liver disease, low sodium diet, low protein, and soft foods. Maybe a fluid restriction, and they're going to need vitamins, no alcohol. We have to tell them not to drink alcohol. Okay, so portal hypertension. All right, so our venous system drains blood from the small intestines, like that has the nutrients, and brings it to the liver through the portal vein. Okay, now as the liver gets more disease, the portal vein has to try to press against the tension in the liver. And it can't always do this, so it creates a lot of collateral vessels. So like, for example, in the gastric area or in the esophagus, in the abdomen, the patient's going to develop what's called caput medusae, which is snake-like belly, and hemorrhoids. Okay, so this is important to know what portal hypertension can result in. So it's going to result in ascites, caput medusae, hemorrhoids, esophageal varices, hepatic encephalopathy, and then it also results in splenomegaly. So this is why they're going to be at risk for anemia, leukopenia, which makes them at risk for infection and thrombocytopenia. Okay, so varices, remember, somebody will present either vomiting bright red blood, or they could have black stools, so you're going to look for that. Okay, now I'm going to talk about the varices, because this is highly tested because somebody could die from these. So every patient that has cirrhosis needs to be screened with an upper endoscopy for varices. They're going to be put on a non-selective beta blocker like propranolol. And this is not to reduce their blood pressure, but it reduces the portal systemic hypertension, but it's not given for their overall blood pressure. That's what I'm trying to say. And so it reduces the chance of bleeding. All right. Infections need to be treated aggressively because it's been shown that patients with infections are going to bleed more easily. And you never want your patient like coughing a lot if they have varices, because they could pop one of those varices, okay? Octreotide is the drug you're going to give, and this reduces blood flow to the splenic venous bed, so it's going to decrease portal hypertension. Octreotide can be used in any patient. Vasopressin is another thing they can give. The problem with vasopressin, it is a pressor, but it's not selective. So it will reduce the blood flow to the portal system. However, it's also going to constrict the vasculature in other places like the heart. So you never want to give this to somebody that's had an MI. You're going to monitor for ST changes on the ECG, and also you would monitor for dysrhythmias, chest pain, okay? Those are the things you would monitor for. Now, patients do not go to, if say somebody has a bleeding ulcers, they're not going to go for emergency surgery. They're going to have an upper endoscopy, and they'll either be the varices are either going to be banded, much like hemorrhoids are banded, or sclerosed. So the physician would put a medication in there that makes the varices like disintegrate and slough off, and they'll just go through the digestive system and be they'll come out with the stool. So as a Hail Mary event, if somebody's had endoscopy, or you may be in a rural hospital that doesn't have endoscopy, they would have this esophagogastric tamponade balloon. Now, let me see if I can get this. So, okay, look here. See, you blow up, you put it in like an NG tube, and there's two balloons. So you blow up the esophageal balloon and the stomach balloon, and it's going to tamponade the bleeding, meaning it's going to put pressure on it and stop the bleeding. The problem with this is if this migrates up, it's going to include the airway. So you have to have scissors in the room so you can cut it, which is going to deflate the balloons immediately. Tips is going to be like a last-ditch effort to decrease portal hypertension, and they do this in interventional radiology. They'll put like a little shunt between the portal vein and the hepatic vein to kind of divert that blood. Okay, so somebody's bleeding. Remember, they could need packed red blood cells. They may need FFP. Remember, FFP contains all the clotting factors, and people with liver disease are not making their clotting factor. And they may need platelets because they'll have thrombocytopenia. Okay, so somebody bleeding, you're going to make sure you're paying attention to their airways, do a respiratory assessment. You're going to have to suction that blood out. Also, a neuro assessment. Let me explain what happens. When somebody has bleeding varices, they are going to swallow that blood. When you digest blood, it's going to increase your BUN. It's digested as protein. So you need to do a neuro assessment after somebody has a bleed because they could develop portal systemic encephalopathy. All right, the Sensation tube I talked about. You have to stay with your patient when it's inflated. Can never inflate longer than 12 hours. Make sure you're suctioning the mouth because they can't swallow. And then cut the balloon if they're in distress. Vasopressin I talked about. You're going to look for chest pain, ST changes. Don't give it to people with coronary artery disease. And then octreotide can be given to patients with coronary artery disease. And then remember the endoscopic treatments. They go to the endo lab, so that's good. And then after they bleed, you're going to look for portal systemic encephalopathy. So hand tremors, wrist flapping, inability to concentrate, sleeping all day and being awake all night and fatigue. The motions are going to be all over the place. Okay, so just remember that. So what you're going to do for a change in LOCs, remember your brain runs on sugar and oxygen. So check an O2 sat, check a sugar, do a neuro assessment, compare it to the baseline, and call the provider to get an ammonia level ordered. Okay, have them extend their arms so you can check for asteristics, check their electrolytes, and think safety. Okay, these are the conditions that precipitate hepatic encephalopathy, and we talked about two of these, which are important for you to know. So that would be hemorrhage in the GI tract, and excessive protein in the diet can lead to encephalopathy, and of course, any kind of sedatives, opioids, or analgesics could also lead to encephalopathy. Okay, now in the next cirrhosis kind of mini lecture, I'm going to give it to you in a different format. If this looks too busy to you, just remember what I said before, okay? So we're going to kind of go around and talk about the different kinds of findings you're going to see in somebody with cirrhosis. This is a multi-system disorder. So, neurological findings, somebody with portal systemic encephalopathy is going to have reversal of their sleep-wake schedule. They'll have hand tremors and flapping of the wrists, so ask them to extend their arms to assess for asteristics. Inability to concentrate, confusion, lethargy, and then peripheral nerve degeneration and paresthesias. Okay, so that's like a safety issue when they're walking, etc. They have to wear shoes, all that stuff. All right, so to treat encephalopathy, they're going to get a drug called lactulose. So that decreases the pH of the bowel, and it helps decrease the production of ammonia by bacteria in the bowel. So it also facilitates the excretion of ammonia. The diet for people with encephalopathy is low protein diet to prevent confusion. So if somebody has a change in their LOC, assess and compare it to the baseline, do the O2 sat and the blood sugars, get their vitals, call the provider for an ammonia level, and ask the patient to extend their arms and look for a hand wrist flap. Okay? Now, the next I'm going to talk about are the GI findings. So the GI findings in cirrhosis include anorexia. Anybody with liver problems gets anorexia, like even hepatitis early on, they're going to get anorexia. Hemorrhoids, that's due to portal systemic hypertension. Abdominal pain in the right upper quadrant because that's where the liver is. Clay-colored stools because they could have biliary obstruction. Varices, malnutrition. Remember the fetor, that's a sign of encephalopathy, and splenomegaly. And we talked about the blood cells being depleted. So remember the diet in end-stage cirrhosis. They're going to be on a low-protein diet to prevent portal systemic encephalopathy. They need to eat soft foods to prevent bleeding. They need a low sodium diet to prevent ascites. They need no alcohol, and they need to eat small, frequent meals. We talked about, we're going to go to the endocrine reproductive findings. So the body detoxifies hormones, but it can no longer do that. So they're going to have increased aldosterone, which increases the sodium in the body and decreases the potassium. So they will be put on spironolactone. That's a potassium-sparing diuretic to kind of counteract those effects. They have increased ADH in the body because they can't break it down. So so usually they give the two diuretics. They'll give furosemide and a potassium sparing diuretic. Again, they have increased circulation of estrogen. I talked about gynomastica, testicular atrophy, palmar erythema, and spider angiomas. Okay. Um, they can also have renal findings. So hepatorenal syndrome occurs when they're circling the drain. Exactly. So what you'll see is it's like they develop an AKI. So you'll see the urinary output drop and the BUN and creatinine are going to increase. Okay. So with portal systemic hypertension, okay, you're going to be worried about hemorrhage and bleeding from varices. So all patients with cirrhosis need to be screened for varices. They'll be put on a non-selective beta blocker to decrease portal hypertension, not to decrease their overall hypertension in their body. Although that may be an effect of it, that's not why they're put on it. You want to treat infections quickly. The vasoactive medications I talked about were octreotide and vasopressin. So octreotide can be given to everybody. Vasopressin should not be given to people with coronary artery disease. Monitor for your ST changes on the ECG, chest pain, headache, and dysrhythmias. Balloon tamponade can be used. They may need an NG tube to detect bleeding. They may need fresh frozen plasma because that has all the clotting factors, platelets, because remember the spleen acts as a Pac-Man and eats all the platelets. Monitor their respiratory status, like make sure you're prepared to suction the airway if somebody comes in with bleeding varices, and neurostatus, because remember blood is digested as protein and that's going to increase their BUN and ammonia level and they're going to get encephalopathy. So keep giving the lactulose. And how you know a lactulose is working is they're going to have more mental clarity, like their speech will be clear and consistent. They're not going to be confused anymore. So look for those things. Usually you expect 2 to 3 soft bowel movements per day on people with lactulose, but what happens in the hospital is we're all overachievers. The patient gets diarrhea and then doesn't want to keep taking the lactulose. I mean, all you can do is document if they refuse, but really we want to encourage people to take it if we can. I talked about the Sensake and Blakemore too, and you need to stay with your patient, maintain the patent airway, cut the balloon if the patient is in respiratory distress, suction the mouth, ensure the balloon is not inflated greater than 12 hours. You need a scissors at the bedside. All right, for fluid and electrolyte findings, they're going to be hypovolemic despite having a lot of fluid on board. They're going to have ascites, and they need to be on a low sodium diet to prevent or help diminish ascites. So again, with portal hypertension, they're going to develop ascites, caput medusae, which is dilation of the veins in the abdomen, and it looks like there are snakes on their abdomen. Hemorrhoids and large varices, which put them at risk for bleeding, so you never want them coughing a lot. Hepatic encephalopathy. And then with splenomegaly, they're going to have anemia, leukopenia, thrombocytopenia, which can result in bleeding, infection, and fatigue. All right, some of the skin findings. Patient will be jaundiced. They'll have extreme itchiness. The pubic hair changes due to the estrogen. They'll have caput medusae. They'll have spider angiomas and palmar erythema due to the estrogen. Ecchymosis and petechiae due to the portal systemic hypertension and splenomegaly. Hematological findings, again, the anemia we talked about, the thrombocytopenia, and they'll have impaired coagulation and increased PTINR because the liver makes the vitamin K dependent clotting factors and it can no longer do that. All right, so they're going to be on bleeding precautions. They may need vitamin K or FFP. Remember, give FFP first if they're bleeding, because that's going to it has all the clotting factors. Vitamin K is going to take a little bit longer to kick in. Check your CBC with platelets and coagulation studies. Again, the hematological findings. Remember, the leukopenia is going to result in spontaneous bacterial peritonitis. Okay, metabolic dysfunction of the liver. They're unable to make plasma proteins, which results in infection, but also clotting abnormalities. They'll have muscle wasting and low albumin, and they will have decrease in clotting factors. If they have ascites, they're going to be at risk for hepatopulmonary syndrome, which means they get extreme shortness of breath. Okay, so O2, daily weights, make sure the head of bed is at least 30 and the feet are elevated to decrease edema. You're going to measure the abdominal girth in respiratory assessment Q4. So they'll have shortness of breath, hypoxemia, and dyspnea if they develop hepatopulmonary syndrome. Interventions to reduce ascites include the low sodium diet, your diuretics, and fluid restrictions. Possible, not always. Okay. So patients that have hepatopulmonary syndrome and are extremely short of breath may undergo a paracentesis. They may do a paracentesis also if they suspect somebody has spontaneous bacterial peritonitis. So you need to know the nursing implications. You're going to weigh your patient before and after. They need to be positioned supine with the head of bed elevated. Make sure the consent is on the chart too. Remind the patient to remain still, and they need to empty their bladder before, so that the provider doesn't inadvertently perforate their bladder. Okay, so you're going to take those vital signs, frequent vital signs. They're taking off usually a lot of fluid, so you have to monitor for shock. So look for tachycardia and low blood pressure, tachypnea afterwards. Okay, monitor the urine output and make sure they're making urine. Weigh the patient. You need your post-procedural vital signs. They're going to be on bed rest for a little while. All right, liver transplant. The most common reason people get liver transplant is because they have hepatitis C, which results in cirrhosis, and it could result in liver cancer. People that would not qualify for a liver transplant include those with severe cardiovascular or pulmonary diseases. This is a long operation and they're not going to survive it. Also, people with metastatic tumors to the liver, anybody that can't follow instructions. It used to be that they weren't given to people that were still drinking or using drugs, but that is changing. So that may not be a factor anymore. It depends on where the liver, what system the liver transplant is being done in. So patients taking immunosuppressive medication need to avoid crowds and sick people. So usually if the liver is going to be rejected, it'll happen on the 4th to 10th day. Now, anytime somebody has an organ transplantation, they're going to be under extreme stress. Their body is going to be under extreme stress if the body starts rejecting the organ. So they're going to have tachycardia. Okay? They're going to have a fever. In a liver transplant, they're going to have pain in the right upper quadrant or flank pain. Now, whichever organ was transplanted, what you're looking for in rejection is a return of disease. So in this case, when we're talking about a liver transplant, we're looking for diminished bile drainage or a change in the bile color. Now, they'll have a T-tube post-op. You're looking for increased jaundice, increased bilirubin, LFTs, and a prolonged PT. In other words, you're looking for the patient to go back in liver failure. Okay, so early on in cirrhosis, they'll have high LFTs, high bilirubin. If they have encephalopathy, they'll have a high ammonia. The PT-INR is going to be prolonged. And protein, albumin, platelets, hemoglobin are going to be low. White count is going to be low. Glucose can be either high or low. Okay, this is what caput medusae looks like. Snakes on the belly. All right, that's it for cirrhosis. Now, I know you're probably like, oh my God, this is too much information. And you're right, this is a lot because I haven't even done upper, lower GI diseases. Okay, so this is a lot for exam 3. So start studying early, please, please, please. Okay, I want to compare uremia with end stage liver disease because the signs and symptoms are similar in both conditions, even though the reason for them may be a little bit different, okay? So neurologically, they both can develop encephalopathy or confusion. And how that's treated is with a low protein diet. Now, people with end stage liver disease are going to, if they're end stage, remember, they're going to need soft in addition to low protein, and they're both going to need low sodium diets. Okay, so renal failure versus end stage liver disease, um, same kind of signs and symptoms. People with renal disease can develop asteristics as well, so that's something you would look for. They both have neuropathy, so that's another thing you look for. Okay, now when it comes to anemia, they're both going to have anemia, so the symptoms of anemia. In uremia, the anemia occurs because the kidneys can't make erythropoietin, okay? And so that's why it happens in uremia. It happens in end-stage liver disease because the spleen becomes inflamed due to portal hypertension, and the spleen acts as a Pac-Man and eats all the red blood cells. In uremia, they have platelet abnormalities, so they're going to be at risk for bleeding. And it's not that the uremia decreases the platelet level, it's the uremia makes the thrombocytes not work as well. So they could have a normal level, but they're still going to be at risk for bleeding. And again, liver disease, they're at risk for bleeding because they can't make clotting factors, but also because of the splenomegaly eats the thrombocytes. They're both going to have anorexia, nausea, vomiting, diarrhea. Okay, so they both have that. They both have change in skin, like in end stage liver disease, it's going to be jaundice. And with uremia, it's going to be sallow, like that. It's kind of yellow, tan, gray color. They're both going to have pruritus. And in uremia, it's due to the high BUN and creatinine. And in end stage liver disease, it's due to the high bilirubin. Okay, endocrine, they're both going to have infertility disorders and amenorrhea. Okay, in uremia, they're going to have renal osteodystrophy, which you don't see in end stage liver disease. So they're going to be at risk for pathological fractures. They're both going to, they both are going to potentially have edema. End stage liver disease has the ascites. Okay, and end stage liver disease has also the varices that you have to watch out for. But anyways, I just thought it might be nice to compare and contrast because they have a lot of the same signs and symptoms. All right. Lastly, I'm going to talk about acute pancreatitis. So acute pancreatitis results when the pancreas auto-digests itself. So the pancreas, as we learned in the previous unit, has an endocrine function of secreting the insulin, but it also has an exocrine function in which it secretes digestive enzymes that aid in our digestion. So if something triggers the pancreas to release these enzymes early, the pancreas will then auto-digest itself. Okay? So there's a lot of different reasons people can get pancreatitis, but the two reasons I want you to know about include alcohol abuse, and they don't have to be an alcoholic. It could be like a binge drinking, um, and biliary obstruction. So go back and look at the video I did about the biliary tree. That will explain a lot, okay? So anyways, whatever the two triggering, either alcohol or biliary obstruction, it 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 triggers the pancreas to release pancreatic enzymes early, and it results in autodigestion of the pancreatic tissue. And I'm just going to shoot to the end. Because of this, they're going to be at risk of septic shock, hypovolemic shock, because they can bleed out because it causes hemorrhage, the digestive enzymes. They'll be in severe pain. They could have peritonitis, and they'll develop what's called adult respiratory distress syndrome. So again, the two most common causes are alcohol and biliary obstruction. And I did describe in another lecture that you're looking, if they have biliary obstruction, that's going to stress the liver out, and you're looking for those elevated AST, ALT, okay, and elevated bilirubin, jaundice, clay-colored stools, all those signs and symptoms of biliary obstruction. Okay, acute pancreatitis, the pain assessment, they are going to present with pain mid-epigastric or in the left upper quadrant due to the inflammation in their pancreas. It's sudden, it radiates to the back, it can radiate around to the back like in a circular motion. It can radiate to the left flank or the left shoulder. Pain is continuous. It's described as boring, like ripping through the body, and the patient's going to be guarding. The pain is made worse by lying supine. They need to lay in the fetal position and bend the knees. So it's called the left lateral decubitus knee bend position, or by sitting upright, leaning forward, and bending the knees. Okay, now pain is expected to get worse. It's going to wax and wane. So I'm not really worried about it because I can medicate it. But remember, okay, so patients with pancreatitis are going to be at risk for atelectasis, pleural effusions, and ARDRS. They're also going to be at risk for hypovolemia. So you need to prioritize your ABCs before you take care of pain. All right. So they may lose a little weight because usually they're MPO. We keep them MPO because we don't want the pancreas to secrete any more enzymes. So that's a reason. We also keep them on bed rest to decrease the pain because when you're moving around, it's going to rev up your metabolism and it's going to cause the pancreas stress and to release enzymes. So bed rest, MPO, in narcotics, possibly a PCA. All right. So again, they're going to have a temperature because the pancreas is inflamed, and expect for jaundice because if they have biliary obstruction, if they have pancreatitis due to biliary obstruction, it's going to show up as jaundice or icterus. Okay, so look for that. Pleural effusion, so your lung sounds may be diminished. Look for dyspnea, orthopnea, like they can't lay flat. Gray Turner sign. So, okay, so Gray Turner sign is bruising on the flanks, and Cullen sign is going to be bruising around the umbilicus. And it indicates, they both indicate retroperitoneal or intraperitoneal bleeding. Okay, so you would have to assess your patient further to see if they're symptomatic from these signs. Like, are they still bleeding, or you know how like a bruise can increase over a couple days and then it just is stagnant. So it may be that the bleeding was earlier. So, but you would still make sure you are doing a good assessment. All right, so remember abdominal assessment. You are going to inspect before you listen. Now, they may have a paralytic ileus. If they're passing flatus or having a BM, that means they still have peristalsis, so no NG tube. then you percuss, then you palpate, okay? So the labs you're going to see in pancreatitis is going to be an increase in amylase. That's going to rise after 12 hours and will remain elevated for 2 to 3 days. The lipase is going to increase, and that's the most sensitive indicator. And that's because amylase can increase for other reasons besides pancreatitis, but lipase is only elevated in pancreatitis. Also, lipase stays elevated for 7 to 10 days. The alkaline phosphatase is going to be increased if they have biliary obstruction. The bilirubin will be increased if they have biliary obstruction. The ALT is going to be increased if they have biliary obstruction, and so will the bilirubin. White count's going to be high for any type of pancreatitis. The BUN is going to be high for any type of pancreatitis. The glucose could be high, more so in chronic versus acute pancreatitis. Magnesium is going to be low. Albumin is going to be low. Platelets low. The prealbumin is the best measurement of acute malnutrition, and it will be low. Calcium is going to be low, so look for those signs of low calcium. All right. So your interventions, prioritize your respiratory assessment, your IV fluids. You want to decrease inflammation and relieve symptoms and anticipate the treatment. So assess the respiratory status Q4, O2 if they need it, control the pain by interventions that decrease GI tract activity. So keep NPO, keep them on bed rest, no smoking. Smoking increases GI tract activity. They're going to need analgesics. They'll need antiemetics if they're vomiting. And then NG tube if they're not passing flatus or BM. Assess for your low calcium, and we did that in the last unit, so remember to review that. Look for the circumoral tingling, the Schwastex, the Trousseau sign. Okay. Now, again, let's review the treatment. NPO in the early stages and IV fluid. Antiemetics, PRN, IV fluid resuscitation, NG if no flatus or BM, and then pain management. And remember that you're always going to prioritize the respiratory and the IV fluid before the pain. Now, we do need to medicate, obviously, because you're not going to get good information out of your patient if they're in a lot of pain. All right, diet during the healing phase of pancreatitis. So the biggest factor is fat. They need low fat because fat stimulates lipase. So you don't want to do that. They'll need small, frequent meals. They need supplemental protein shakes. Avoid alcohol and caffeine. No spicy foods. The food needs to be bland. No fat and no smoking. All right, chronic pancreatitis. So this happens after repeated bouts of pancreatitis. Chronic pancreatitis has, exacerbations and they have remissions, okay? So alcoholism is what causes chronic pancreatitis. So patients with chronic pancreatitis can develop diabetes type 1 as an adult, and you know that's unusual if an adult acquires diabetes type 1, okay? They're going to get malnutrition due to malabsorption when they're having an exacerbation. Okay, so look at the prealbumin level in the albumin, it'll be low. Assessment findings, they're going to have steatorrhea because they can't digest the fat, and steatorrhea is fatty stools. They're going to have jaundice, they're going to have dark foamy urine, and look for the 3 P's of diabetes. Now they're going to need to take pancreolipase. They take it with these are like the pancreatic enzymes, right? So you're going to either sprinkle them on food or they'll take it with meals and snacks. And it's for chronic pancreatitis only, so make sure you're reading carefully on exams. All right, so teach the patients not to chew or crush the capsules. take with all meals and snacks and follow with a glass of water. Do not mix the enzymes in protein-containing food. Wipe the lips after taking the enzymes to avoid skin irritation. And also evaluate for the effectiveness. So you should see a decrease in steatorrhea, an increase in energy, weight gain. When they go home, when patients have acute pancreatitis is one of those conditions where people can have like a mild version versus they can be really sick. So in chronic pancreatitis, obviously if they're having an exacerbation, they're going to be wiped out. They're going to be really tired. So you need to ask if there's any stairs in the home for your care coordination, because they're going to need a bed on the first level. They're going to need either a toilet or, this is for chronic, they'll need like a toilet or a bedside commode because they're going to have steatorrhea and they could have frequent stools, okay? So again, the diet is going to involve avoiding alcohol, high-fat foods, no smoking. Chronic pancreatitis needs to take their PERT therapy, so that's the pancreolipase. Activity, you're going to assess for how many stairs are in the home, and also they need frequent rest. You need to tell people with chronic pancreatitis to report an increase in the 3Ps if they don't have a diagnosis of diabetes, and report an increase in frothy and fatty stools. So hopefully this steatorrhea is going to get better, and no ETOH at all. All right, that does it for the biliary tree continued.